Welcome to the plenary panel this morning on health system strengthening, view from the ground. I'm very pleased to be moderating this discussion this morning at my first time at CCIH on a subject that is so important to those of us who work on the ground in public health and are at the front lines of responding to the needs of vulnerable communities. So as mentioned, my name's Allison Bear. I'm the Vice President of IMA World Health and Lutheran World Relief. And I know that IMA World Health is a well-known organization and figure at CCIH. We've been engaged for a very long time with CCIH. But for those of you who are less familiar with Lutheran World Relief, I wanted to take a minute and talk about what's happening with our two organizations. So in January of this year, we announced that Lutheran World Relief and IMA World Health are merging, and we're really excited about what that means for our new combined organization. We expect the merger to be complete by this fall, and this merger will combine decades of experience and expertise of two excellent faith-based international humanitarian organizations. The two organizations share a very long history as mutual partners, and in fact, Lutheran World Relief was one of the founding members of IMA World Health. We share similar values and approaches to our mission, and our work is very complementary. So LWR is known for its work in agriculture, improving rural livelihoods, and humanitarian response, whereas IMA works across the different health disciplines. One thing that Lutheran World Relief and IMA share in common is a longstanding dedication to working with local partners to better serve families and communities and to ensure the sustainability of our efforts, which is what sort of leads us to the topic today. Health system strengthening is so central to our work at IMA World Health because we know that strong, responsive, and resilient health systems are the key to meeting the needs of families and communities. And to succeed, health systems and the people within them need to have the tools, resources, training, and support to function effectively. So IMA World Health, just to give a couple of examples of the type of work we do, we work extensively with the faith-based health sector in low-resource settings, because in places with few resources and very little support, one institution you will always see in communities is a church, often a humble presence, but one rooted in community with open doors and compassionate hearts. IMA develops the capacity of faith-based health networks to improve the quality and the performance of their health facilities through close collaboration and partnership. IMA also works with national and local governments through ministries of health, working across all 6 of the WHO health systems building blocks. In DRC, for example, we've helped the Ministry of Health scale up a national digitalized health information system on the DHIS2 platform for those of you who sort of are engaged in health information system work. It's a very common platform endorsed by WHO and used by many ministries of health around the world. In the urban slums of Nairobi, we support county health officials to establish and institutionalize quality improvement teams that ensure that women are receiving high quality maternity care at public facilities. But health system strengthening is most successful when we can encourage collaboration between the different actors who are working in the health space, whether they be government, NGO, faith-based organizations, or corporate entities. That's why I'm so excited to hear this morning about the collaboration between the Uganda Protestant Medical Bureau and Novartis Social Business to carry out capacity building work that empowers village health committees to raise awareness about and screen for non-communicable diseases. Non-communicable diseases are an emerging and rapidly growing health concern in low and middle income countries. And I'm pleased to introduce our first 2 panelists for this session who will talk about this more. So Tonny Tumwesigye is the Executive Director of Uganda Protestant Medical Bureau. Before his tenure at UPMB, Tonny served for 10 years as the CEO, medical superintendent, and a frontline physician at Kasizi Hospital, which is a 250-bed mission hospital in rural southwestern Uganda, where he oversaw the expansion of a community health insurance scheme that became the largest self-sustaining community health insurance scheme in Uganda. Through his dedicated leadership, Dr. Tonny guided UPMB to earn the Grant Thornton Institute of Uganda Corporate Governance Award for the NGO category. Can I ask Dr. Tonny and Alfred to come on up? Dr. Tonny and Alfred. Welcome, have a seat. Also joining us is Alfred Wabulembo. He is a committed Christian who is passionate about access to health care. He worked with Medical Access, a UNAIDS drug access initiative in Uganda, working with implementing partners to ensure a steady supply of ARVs at affordable prices. He then joined the Malaria Initiative, a Novartis access initiative, in the fight against malaria. And currently, he's responsible for Novartis Social Business's work in Uganda, Rwanda, and Tanzania, where he is trying to accelerate access to non-communicable disease medicine, disease screening and awareness, and community education. Please join me in welcoming these panelists today. So we have one mic, two mics between us. So I'll ask the question and then I'll pass it over to you and you can each take a mic, okay? So my first question is for Dr. Tonny. Can you please describe the relationship between UPMB and Novartis Social Business?
Thank you, Alston. Our relationship with Novartis Access stems from our network, which is a 302 health member unit network. And these cut across hospitals and 15 health training institutions and one medical school that has just started. And this relationship is looking at how we can strengthen the systems of UPMB and Uganda at large in responding to the non-communicable disease agenda. And it's not only in the city, but it's also looking at the rural areas and the engagement with the district mechanism.
Thank you. And Alfred, why did Novartis Social Business decide to partner with UPMB in this effort?
Thank you. The reason why we decided to partner with the Uganda Protestant Medical Bureau on this agenda in Uganda, one, we looked at their network. They have a very good, according to us, it's a very good network across the country. So we felt that working with UPMB will definitely give us the access to the number of patients that we are looking at. And also in their network, also the fact that they work very closely with government. So we felt that working with UPMB will reach the community through the faith-based facilities, but also because they are with the government, they are looked at as one of the best partners in implementing activities in the hospitals. Then we would also be touching the patients that visit the government facilities. The other reason is because we looked, UPMB actually reached out to us and they were very willing to partner. So that desire to partner with us also gave us the confidence that then they are going to deliver to the objectives that we have because of, the level of energy that you find within the organization. And I think lastly is also the fact that they have the patient numbers. Looking at the community health insurance that they are running right now, we see that, this is the future of healthcare. So when you're working with an organization that already has something that they are putting on the table, then definitely it's the best partner to have.
So in your opinion, community-based health insurance is the future?
Yes, I look at it, from where I come from, good enough I'm also from Uganda. And if you allow me, I'll tell you that just recently, I'll give you an example. Recently, my mother fell ill. She was in the village, but because she does not have health insurance, we had to spend money to evacuate her from a village which was about 200 kilometers to the city center. Now, if there was vast community health insurance, definitely our mother would have at least accessed the immediate care in one of the neighboring facilities. So where we are heading, definitely we cannot do without community health insurance, and for sure it's the game changer.
So perhaps, Dr. Tonny, you could start, and then Alfred could add about how you think your project that you're working together on can help strengthen UPMB's health systems, but also the Ugandan health system in general.
Thank you, Alison. From the discussion that has started around health insurance, we look at the health system strengthening bit. Under UPMB, we don't do things vertically or in silos. We do a system-based approach. So with our partnership with Novartis, of course, the entry point is non-communicable diseases. But when you look at the way UPMB has been operating over years, we've been waiting for patients. But now we are saying, should we continue waiting for patients who are already dying, or we should be reaching out to these patients wherever they are? So that is the approach that we are now employing. So through the system-based approach, we are looking at leadership and governance at national level. How do we move the non-communicable disease agenda? Why non-communicable diseases? Through all the years that we've been implementing HIV programs, the focus has been on patients to survive. And we're beginning to see many patients surviving, but they're developing non-communicable diseases over years. So that's one of the areas. So from the top side, you are saying, Minister of Health, look, what do we need to do considering what is happening? So part of that, part of the project is also looking at that partnership at Ministry of Health, strengthening that. We are also looking at human resources for health. Most of our health workers in the UPMB sector have been concentrating so much on infectious diseases. And we notice that even when somebody goes to a hospital, they are not able to even check for non-communicable diseases of these patients because their focus is HIV, is TB, is malaria. So we are looking at how do we train these health workers so that they're able to regain their skills from the time when they qualified. And to do that, we are also putting in equipment like BP machines. We are looking at glucometers for testing for diabetes. And we're also looking at health education as part of the process. And as Alfred is mentioning, we're also looking at health insurance at the community level to see how do you bring non-communicable diseases into the health insurance framework. Because many health insurance people do not want to cater for chronic diseases. But we are saying we have an opportunity to give people treatment at $1 a monthly dose. And at that level, we are saying, how do we bring in this so that even the members of these insurance groups are able to benefit? But the other arm that comes in is the supply chain. And through UPMB and of course, Uganda Catholic Medical Bureau that we collaborated to form the joint medical stores, we are strengthening the supply chain component and saying, how do we have the drugs at joint medical stores, but ensure that the facilities are able to manage their drugs through ordering and quantification, but also to understand which drugs to bring on board. And lastly, the issue that we are looking at again around the systems is the referral mechanism. How do we ensure that people who come to hospitals are able to go back and receive these treatment at their lowest point without having to keep moving to the hospitals and vice versa? So we're looking at strengthening the referral mechanism within the UPMB systems, but also referral systems within UPMB and national health systems. Thank you.
Thank you. So I think you actually, with that response, touched on all of the health systems building blocks of WHO. We talked about financing, supply chain, essential medicines, human resources for health, leadership and governance. And then you touched on referral mechanisms. So UPMB has costed out the cost of delivering treatment for non-communicable diseases at $1 per month.
Yes. What has happened is that Novartis has did its mathematics. I don't want to go into that, but Novartis is giving us an offer of treatment per dose at $1 now per month. Now, under the UPMB system, Novartis, through our partnership, we've been able to collaborate and get a grant that will support these system strengthening arms. But as I've put it, we don't do things outside. We tend not to do things, let me paraphrase. Our desire is to make sure that our systems are resilient. And as such, whatever project comes into UPMB, we try our level best to make sure that this is within a mainstream mechanism and not a vertical mechanism. So what we are doing with Novartis, through a grant that Novartis has given to UPMB, we are going to undertake a number of activities. And some of those activities are those that I've tried to break down and give. And we think that through that grant, we should be able to take this to another level. So yes, the costing has been done at facility level. We know what we think is critical, the human resources that are critical, and we are targeting those in the training. But also, one of the things that we are doing is to make sure that the management and the boards of these hospitals are fully into this picture. Because it is their own good that, one, they don't have to wait for very sick patients. We've seen that every time patients come to hospital with diabetes, with severe hypertension, they consume a lot of resources in the hospitals, and the hospitals can't turn them away. So we are saying, look, management, your cost of inpatients around these people is quite huge. How do we turn that around so that you are looking at patients who are coming in, you are giving them the drugs, but also critically, you are true to your mission, okay? Because that, to me, that is the critical one. Otherwise, patients will come in, they consume a lot of treatment, they take a lot of time in the hospital, they don't have the money to pay, the hospital has no choice but to treat them, and in the end, we are seeing that hospitals are struggling. So really, it's about ensuring that the hospitals are meeting their mission, and they're meeting it within the resources that they have.
Great, thank you. So it seems like this project is really sort of at the intersection of a lot of themes that we see moving towards 2030 and the Sustainable Health Goals and achieving universal health coverage, right? You have this emerging burden of chronic diseases, with declining burden of infectious disease. You have this guarantee of trying to ensure everyone has access to care. That's the mandate of the SDG. And then you have all of these issues around how do you finance it, how do you deliver it with this changing burden of disease and changing epidemiology. So the next question I'm going to ask Alfred to describe, this seems like a really interesting partnership going on in Uganda, but where else is Novartis Social Business working in Africa?
Yeah, I mean, we are in quite a number of countries, but I mean, to bring up to speed each and everybody, I'll try to describe what Novartis Social Business is. Novartis Social Business is an initiative that is part of the Novartis Global Health and Corporate Responsibility. So under Novartis Social Business, we have the elements of capacity building, we have community engagement, and then we also have the supply of the medicines that Tonny has been talking about at $1 per treatment per month, $1 factory price. I think that needs to come out very clear. It's $1 factory price per treatment per month. So we have those three segments. There is the community awareness and training, and then we have the capacity building for healthcare practitioners. We believe that, as Tonny said, that it's cheaper if we sensitize the communities and they seek healthcare quite early than waiting for the critical time when there has to be expensive intervention. So that is why we decided that we shall also be part of the community engagement. In countries like Kenya, we codename it as Familia Nawiri, but the general name is Healthy Family. So under the Healthy Family program, we we partner with organizations now like UPMB, and they go out in the communities every day to teach communities about non-communicable diseases and how they can be prevented, why it is important for them to go for screening. To answer your question, where else we are, apart from Uganda, we have been in Kenya for quite a number of years, and a lot of success has been registered so far within Kenya alone. We talk about 1.5 million people that have been actually talked to with regards to non-communicable diseases. We have facilitated 430 healthy camps where people come. We go to communities and invite people in the village to come and be screened for hypertension, for diabetes, and those that are found that need treatment, then they are referred to the treatment facility. And out of those camps, I mean, we've been in position to even diagnose some patients. Over 70,000 of them have been diagnosed with a particular non-communicable disease. Then we are also present in Ethiopia. In Ethiopia, we are doing capacity building. We are partnering with THET, that's Tropical Health and Education Trust. We also partner with the Red Cross in Ethiopia. And we're also looking at a possibility of partnering with the Catholic and the Orthodox Church. We are also present in Cameroon, and we are partnering through the, it's called Christian Baptist Convention. We are looking at getting to Nigeria, to Burkina Faso, Ghana. I think he was waiting to hear that we want to be Ghana. Yes, we look forward to getting as many doors open to us within the continent as much as possible. Outside Africa, we are also in Nepal, Pakistan, and Vietnam. So for me, out of this conference, I'll be very much interested in getting interactions to get to hear from the different people coming from different countries. What is it that we can do together to fight non-communicable diseases?
Thank you. So I want to take a step back because we have a few minutes, and I had the great opportunity to participate in the UN General Assembly high-level meeting on non-communicable diseases last year. And it was very apparent that ministries of health and governments are leading the way, saying, we need to tackle this as an emerging issue in our countries. But there was a problem definition. The problem was, what is a non-communicable disease? Sort of what's in non-communicable disease and what's outside of non-communicable disease. And there was one panel that had a safe surgery person, a diabetes endocrinologist, and I'm just wondering, can you define from the perspective of your work together, which diseases you're specifically talking about working together on when you say non-communicable diseases, just for the clarity?
Okay. The common ones, it's a cardiovascular disease. We have diabetes. We're looking at respiratory disease, chronic respiratory disease. And I think about recently, at least for Uganda, there's one which has been added, which is sickle cell disease as well. Yeah.
Okay, so and hypertension, diabetes.
Yeah, hypertension, diabetes, respiratory disease, and for now we are talking about breast cancer.
Breast cancer, yeah. And sickle cell. Okay, so then our final question for you at this point in the session is, I just wanted to open it up for the two of you to talk about what your partnership experience has been like, sort of maybe the opportunities and challenges and all of this endeavor so far.
Thank you very much. I think so far, starting from the launch, I would say our partnership has started off at a very strong level. Two, I would say the expectation from this partnership is quite high. We had a very powerful launch where the entire Ministry of Health leadership was there. It is even interesting that in Uganda, Novartis is also working through the same mechanism with another organization, but it was very, very interesting that during the launch, the ministry's focus is on UPMB leading this in the country. So I think the expectation of this partnership is quite high. We just had on the 3rd, it's a national holiday under the Uganda Matters Day, and UPMB was leading on the sensitization agenda, and again through the partnership we're able to hold a number of camps. Virtually all the roads leading into Kampala, we held camps in these areas. And you would see the enthusiasm, the response of the population at the Matters Day itself, the sensitizations that were taking place through the mothers, all the women who had come to attend the Matters Day, the men conference, and then of course the general. So I would say the partnership is quite strong, and we pray and believe that as UPMB will be able to deliver on this partnership. I know the first report is about to go out, but we think that we are one of those commendable organizations that will deliver on this partnership.
Yes, I mean, like Dr. Tonny said, I mean, the expectations are very high. For us, the success of Uganda is going to help us to be a benchmark to what we expect from the rest of the countries. In terms of what is happening now, so far, I see a lot of activity that is on ground, and for me, I'm very happy about it. The event that he's talking about, I think he's just being very humble, not to tell you the number of people that were screened, but they are in tens of thousands. And for us, that's remarkable. I know that they also had a session when they were talking to the masses. They invited one of the specialists in the country. There were two of them that were speaking to the pilgrims. They were speaking to them, teaching them about non-communicable diseases. For us, we're excited. I think we see that we are anticipating success with this partnership with UPMB.
That's great, and what a great note to end this part of the session on. Please help me thank our two panelists, Tonny and Alfred. We will have a question and answer session where all the panelists will rejoin us on the stage at the end of the session. But for now, the three of us are actually going to return to our seats. And I'm going to ask Mona to come back up to the podium to spend a few minutes talking about CCIH's initiative to strengthen 30 health systems by 2030.
I'm back, and I'm excited to be here. So, Mona Bormet, Program Director at CCIH when I'm not the Cruise Director, and I'm excited to share with you our new 30 by 30 Health Systems Pledge, strengthening 30 health systems by 2030. So why is this important? Why is CCIH working on this? And we really look to 1 Corinthians chapter 3, so specifically verse 10. According to the grace of God given to me, like a skilled master builder, I laid a foundation, and someone else is building upon it. Let each one take care how he builds upon it. And so for us, when we think about health system strengthening, we're thinking about how we're continuing to build upon the foundation that God has given us. How do we continue to teach, to share, to build, to help others? And how are we vigilant in doing that well, with the trust that has been placed in us by the people that visit our facilities for care and the people in our communities who we go and help with preventative health programs. So for us, it's this verse with an emphasis on the healing ministry Jesus started and how we have to continue to work on it and finish it. The other piece of why we're doing this is the percentage of healthcare provided by faith-based organizations in countries is large. It differs country by country, but we know that while the government provides services in public facilities, there are large percentages of care provided by faith-based organizations, and those facilities need to be strengthened in large health system strengthening programs, not just government facilities. And we also know that faith entities are critically important because without faith-based organizations providing the care they do, especially in rural and underserved areas, large percentages of the population would be without care. So in 2016, our board of directors approved a new strategic plan, and that was created based on lots of feedback from our members. And there are 4 areas of the strategic plan, one of which is health system strengthening. So yesterday, our health system strengthening working group hosted a pre-conference on one aspect of health systems, which is leadership and governance. And for those of you who went, I hope it was a great discussion. So that health system strengthening working group has identified 3 priorities, and they have a paper which will be passed out and distributed tomorrow at their working group. So these are just very high level aspects that are explained in their paper, and I encourage you, if you're interested, to attend that working group, even though the other 3 working groups are equally as great. So just saying. And the other piece is that we see there are lots of needs and opportunities for us to focus as faith-based organizations in health system strengthening, and the reasons why. We know that strong systems are needed. That's not anything new. Tonny and Alfred just talked about this global burden of shifting to non-communicable diseases. And we know that we need to be resilient on an everyday basis, but especially with the turnover of so many emergencies and crises. We know that we need to be self-reliant. We can't always rely on donors. Brian Fickert talked a lot about that last night. And I just said we need to know that Jesus was a healing ministry. He was a healer, and we need to continue that, and we need to build upon that strong foundation. We also know that no one does it alone. So we do these things in partnership, and that's why CCIH is really focusing on health system strengthening, because we are a network of partners. And we also know that we have seen the need and the importance of generating stories of the good work that faith-based organizations are doing that will help us in advocacy to position faith-based organizations for more partnership and more funding in order to improve our health systems. So with that in mind, what are we actually planning? So our overall outcome, of course, is more funding to do this work that encompasses smart policies and long-term organizational commitment for resilient faith-based health services, not just at health facility, but at the community level. And that's really something I need to emphasize. When we think of health system strengthening, we're not just talking about hospitals and clinics. We're talking about whole communities. And it's because we want to see improved health access, utilization, quality, and outcomes from trusted faith-based health services. I was in Ghana in February, and we met with the acting director of the National Health Insurance Fund, and she said to us that CHAG is trusted. Now, how do you measure that? That's something we're discussing, but that's what people say over and over again. Faith-based organizations are trusted. So we need to take that trust in us that is placed in us, and we need to do good work with that trust. So the World Health Organization came up with these health system strengthening building blocks that Tonny referenced, and I'm going to go into these in a little bit more detail, but these are, we've used these as a type of framework for how we're thinking about health systems. And overall, as I said before, we know, and our speakers have said this, Allison said this morning, where there is a church, there is often a school, there is often a health facility, all to strengthen the community. And then a lot of the folks in this room also represent NGOs, CSOs, faith-based organizations, whatever term you want to use. And we believe that we all work together to strengthen our communities. So we're trying to build, we're trying something new, framed in a new way, but we're building on the strength of our partners. And so this is not extensive. We have 150 members. These are just a few examples of strong health systems or ways in which our members are already doing really great things that are known not just in their country or their organization. So these are just a few examples. And so for the past few months, CCIH has been talking to members. Not extensively, we haven't been able to speak with every member, but we've spoken to members in 12 different countries to talk about what are your needs in health system strengthening. This map is a map of where all our members are. It's on our website. But these are just the 12 countries we've been able to hear from. We, of course, want to hear from more. And so what I'm going to do now is I'm going to go through those 6 health system strengthening building blocks, and I'm going to give a short summary of what we've heard, not only from those 12 countries, but also from a mapping exercise we did in Kenya and in Malawi. So under leadership and governance, these are the needs that we've heard, right? There's a lot of successes out there, please don't get me wrong. But the needs we've heard in leadership and governance is specifically are we need staff to be more efficient, we need them to act with integrity, to avoid waste and increase resources. Overall, they need leadership that are not just strengthened at the leadership level of the headquarters of an organization, but down to the community level. We need field staff to be strengthened. And we need leaders with a skill mix. So not just who can run meetings, but who can think big picture, who can analyze, who can prioritize, who can plan. And I don't think this is very new, and we need governance of board members. In a lot of faith-based facilities, maybe this will be sensitive, a lot of faith-based facilities or networks, your board may be made up of religious leaders who don't have health experience. So how do you also have a strong board governance? Under health workforce, a lot of the issues that came up were just around training and high staff turnover, which is also related to finance because it's related to how people are paid. And do we have enough staff to meet the needs? Under financing, I don't think this is any surprise. All about resource mobilization, of course, people were concerned, but people were concerned about resource mobilization not just outside, but within their country. How do they mobilize resources within their country? And the biggest issue was not many groups had cost recovery systems. So as donor funding may decrease, do they have a system in which they are going to be able to meet the needs to keep their facilities and their programs going? Or is everything donor reliant? Under health information systems, there was a big focus on monitoring and evaluation. And we hear this a lot from outside groups. Oh, FBOs don't really monitor or evaluate their programs really well. And I would say that's mixed. And I think a lot of our groups do have M&E systems, but they're not often funded. And so it's how do we make M&E systems part of our everyday activities? And so there were a lot of comments about better systems, but systems that are also cost recoverable, that don't have a huge price tag. So that was part of HIS. Under access to essential medicines, this was also very closely related to financing. So in order to have medicines, in order to have a strong supply chain, in order to be fixing equipment and not having someone from another country come fix your equipment, there were a lot of things related to how do we pay for those pieces if the government is not paying for those pieces. So it's a cost recovery issue. It's being a self-reliant issue. So that came up over and over again. And under service delivery, the biggest pieces were about what I'm going to call upkeep. How do we pay for water? How do we pay for electricity? How do we pay for cold stain storage? How do we upgrade our hospitals that were built in 1920 by a missionary who came to our country? If we're not allowed to charge patients, if there's, in some countries, the government says you cannot charge for these services. And if you're not allowed to charge patients, then how are you cost recovering in order to pay for water, in order to pay for electricity? So in Malawi and Kenya specifically, we have a summary of both of those meetings on our website under our resources section under health system strengthening. But at the end of the day-long mapping exercise, I asked the folks in the room, can you prioritize these 6 building blocks? And the reason I show this slide, it's not comprehensive of every faith-based organization in the country, and you can see who participated in the summaries online, but I think it's a very important slide to show the importance of country context, right? And the importance of organizational context. So in Malawi, of the groups that were there, they said leadership and governance is the issue they need the most help with. In Kenya, it was service delivery. So different countries, different things. So now how will this work? We have this 30 by 30 initiative. So I think it's important to say this is not about CCIH. It's about you. It's about our members. It's about our affiliates. What are you doing? How can we partner? How can you partner together? That's what we want to emphasize here. And we've been asked a lot, which health systems, which 30? And I think it's a lot for us. It's about what do you define as high need, low investment? Are you working at national or subnational systems? And we hope to find examples of how our members and affiliates are working together to complement each other. And we really hope there might be more than 30 health systems that are strengthened by 2030. So we have a theory of change because that's what we do. It's fun, right? Brian talked about our story change, our theory of change. So this is just our example of activities that we hope, and once again, our impact is we want to improve health access, utilization, quality outcomes from trusted faith-based health services. So there's a few pieces where we would like your feedback. This is a limited amount of time to discuss this. And so on Tuesday, an email will be sent to the entire CCIH membership with a much larger slide deck explaining what's happening. And we're leaving it open for comments for 30 days, basically. We ask that you review it, that you say CCIH, this is missing when you're talking about health systems, or yes, I agree with this, or please add this, or whatever your feedback is, please send it, and then we will revise what we think our 30 by 30 health pledge is, and we'll make it public to the world. It'll be so exciting. So please send comments. And then when we make it public, we're going to ask our members to make a pledge. You'll be sent this link, and there will be questions in there. You know, who are you, what's your name, la la la, joy like that. And then what country or countries are you making a pledge to work in? What areas of health system strengthening? Is it related to a specific health issue area, or is it broad? Who are you already partnering with? Who do you hope or want to partner with? Our goal, of course, is to have 30 members commit, but more than 30 would be great. And then our hope is to take all of that information and create what we're calling our pledge book. It will not be a physical book. It will be a soft copy that we will hopefully share with donors and partners and say faith-based organizations have already identified what their needs are. Faith-based organizations have already done an analysis and said, this is where we need to be strengthening our health systems. Where can you partner with us? We don't want to wait for an RFA or something to come out from a donor. We want to proactively say, these are our needs. Where can you partner with us? So, thank you. Look forward to your questions.
Great. Great, thank you, Mona. So I have with me on stage now Peter Yeboah. Peter is the Executive Director of the Christian Health Association of Ghana, or CHAG. CHAG is the largest private not-for-profit and non-state provider of health services in Ghana. And he is also the chairman of the Africa Christian Health Association's platform, or ACHAP, which is a member network organization representing over 41 Christian health associations and health networks in sub-Saharan Africa. Peter holds a joint Master's of Science in Health Policy, Planning, and Financing from the London School of Economics and the London School of Hygiene and Tropical Medicine, as well as a Master's of Public Health from the Royal Tropical Institute of Amsterdam. His interest and passion is in reigniting primary health care towards attaining universal health coverage in sub-Saharan Africa. So welcome, Peter.
Thank you very much for the kind introduction.
So Peter, I'm wondering if you can just provide a response to the points that you've heard both from the Uganda partnership as well as from Mona, and give us your thoughts on what wasn't mentioned by the other speakers that we need to be keeping in mind when we're thinking about strengthening health systems.
Yeah, thank you very much. I realize that I'm all alone here, so kindly save me. The panelists were too. Thank you so much. Yeah, that said, let me right away give a quick comment on the first panel discussion and then Mona's contributions. One is that I realized that there are several pathways of adopting health system strengthening. And the Ugandan example shows that they use the NCD pathway to do that. That is very great, so they're highly commendable. I recognize that it was disease-focused, and that is one way, and there are several opportunities to broaden the service delivery scope, definitely, so that it could really be all expansive. Coming back to Mona, there was one particular phrase she used consistently, and that has resonated throughout yesterday or the sessions. Trust, trust, trust. I describe trust as the software of health system strengthening, whilst all the 6 health system building blocks are the hardware of health system strengthening. That said, you need the interface to ensure that all of them become platform or environment for achieving universal health coverage, very necessary. But probably the question that was not asked or that was not clear is, how do we objectify trust? Indeed, trust is a social capital. Trust is needed. And just as faith is the currency of Christianity, trust is the face of health system strengthening. And that is highly commendable on that. We recognize that. So I've been asking myself, what are the missing gaps? How do we use trust? How do we build and leverage trust? And throughout the discussions, and consistent with the theme for this particular engagement, a strong community for health, for lasting health, emphasis community. I have 3 areas where we can look at to complement, to support and complement all the areas. Probably they are embedded and yet just an emphasis. One is community ownership and participation, very necessary. We are realizing suddenly that the community is no longer the passive recipient of our services. They are active consumers. In fact, they are making choices. For years, Christian health facilities have presumed that they are the source of quality health services. And yet suddenly in Ghana, we are realizing that patients are making choices. They are boycotting some of our Christian health services and going to other places, all because they are no longer satisfied. So how do we build a sustainable health system? And how do we ensure that the target beneficiaries are included right at the planning stage? I think we have to empower the community, and we have to fulfill our mandate of ensuring that we provide the type of services that are needed, that are complementary, and that are accessible and affordable, and especially acceptable to them. Very necessary. I think in that way, our objective of building a strong, resilient, sustainable health system will come to fruition. By the way, they are the gatekeepers of our services. They determine demand for our services. And they have the right, as we demonstrate, as we saw in DRC, remember, without the community, because they never trusted the health system, they boycotted the Ebola vaccine. So the trust deficit means that engagement with the community is indispensable, and making sure that they are part and parcel of the system. That is number 1 area we have to look at. Number 2 is partnership development. Partnership development. We have partners in the global north, they come in, but we are experienced that, by the way, in Ghana is now declared as a lower middle income country, and that has led to withdrawal of our traditional partners. Now we've had to rely on government. How do you rely on government and yet maintain your identity? We need to be innovative and dynamic in relating to government, build strategic partnerships in such a way that the job you are doing for government is recognized. By the way, we believe strongly that the primary responsibility of health service provision is that of government. And faith-based are not in to supplant that role. We are there to complement and supplement government services. And therefore, our negotiation with government is such that the government should play a vital role in making sure that we fulfill our mandate properly in support of their original responsibility. So partnership with partners, partnership development is indispensable if we are to go that pathway. Beyond that outside partnership, we are looking at intra-partnerships. How do we harness and harmonize our efforts as Christian health networks Network management, the diversity is a strength, but sometimes it can also be a source. It's a source of blessing, it's also a source of conflict sometimes. How do we harness that diversity in such a way that we are able to build that strong community within and without? Very necessary. And probably finally, research. Research. Faith-based providers produce lots of data, and we are always used as a source of extractive research. I don't know whether because we are shy, we heard of documenting stories and telling stories. How can we build that research culture so that we use data, analyze data, and use it for decision making and improve our health system for sustainable service delivery and to build that strong community? So these three areas probably could complement all the brilliant submissions made by my friends: community participation and ownership, partnership development, and research for health. Indispensable areas in complementing the hardware and software of the health system development there.
Wow, that is a great response, and I hope that it's generated some questions. Yes, thank you, Peter. So I hope that has everyone thinking and generating some questions, because we're going to move to the final part of the session this morning, which is an open question and answer for the audience. We're going to bring all of our panelists back up. We're going to have to do a little stage reconfiguration here. Please stay. Peter, don't go anywhere. So we're going to do a bit of a stage reconfiguration to get chairs up here for everyone.
Hi, Dan Martin with the Centers for Disease Control and Prevention. And Peter, you lobbed me a softball to help with my question, so thank you. It was when you mentioned about the element of complementing rather than merely supplanting government services. I'd like to actually take it a step further and suggest that it really has to become a partnership, because missing from this, and Mona, I grant I should have been on the phone calls and I wasn't, it's missing from the health system strengthening story as well, I think, is the entire public health component. We've talked a lot this morning about things that have to do with service delivery, the providing of care. It's vital, vital, vital. I would never want to devalue it. But I'm not hearing anything about surveillance. I'm not hearing anything about the broader picture of what is the burden of disease. The research that you also alluded to, Peter, a big piece of that is what are the things we need to be focusing on in an area. And until we engage with a much broader area than just the catchment area of our individual service provision facility, there's no way we can capture that stuff. Anecdotally, I've recently visited a mission hospital, powerful mission hospital in one country in West Africa that had never been included in the capturing of data in the National Integrated Disease Surveillance and Response System. And that's not the fault of one side. The government wasn't coming knocking on the door either. But so where does this whole engagement with the broader public health picture come into what both of you are describing?
Thank you. Who would like to?
Very brilliant question, very intuitive. I would like to answer that question from the perspective of incentives for service delivery and sanction that is also leading to mission disconnect. I will cite my country as an example. Before the advent of the National Health Insurance Scheme, service providers were providing that comprehensive service delivery, curative, promotive, preventive, rehabilitative. There were that missionary incentive. Then come the introduction of the National Health Insurance Scheme that only reimburses disease treatment. So when you diagnose and treat diseases, you are paid. But when you go out and prevent cerebral malaria, you are not paid at all. So the incentives shifted to clinical treatment of diseases. So much so that suddenly mission facilities are seeing patients as money-making ventures. That is, identity crisis, ethical value. So the more clients you see, the more money you get. And I'll say this is very sad incentive at there. So the question we have to ask ourselves is, how do we fund or finance comprehensive service delivery, primary health care package that that have been our brand for inception? What financing mechanism do we evolve to preserve, protect, and promote our missionary values of holistic health and healing? These are the issues that we are all facing. I think that is a debate that we have to look at. And also talking about data, research, and the rest. So it is often said that if you're not at the table, you end up in the menu. Yes. If you're not at the policy table, you end up in the menu. But how do you get there? It's about visibility, representation, documenting what we do properly, demonstrating our presence and coverage, and having that legitimate presence at the policy table. I think that is one key area that we are all forgetting. How do we document or map? I was happy with the mapping services that are there. But faith-based service providers probably have not built that orientation for data, collecting, analyzing them, and using them to improve services, also to influence policy and practice of health services. These are the areas I look at. So let's look at incentives, let's look at attitude, orientation, and capacity for research and data. That's how I'll answer the question. Thanks.
Thank you very much, Peter. And thank you very much for that question. In our project, or in the work that we do, that's one of the areas that we've been looking at. And how do you feed whatever you're doing into the national system? So part of my team that is here, or even part of the work that we're doing, is the National Health Management Information System. As UPMB, we don't run a parallel system. We strengthen our facilities to input data in the national health system, irrespective of its flaws. Now, for this particular project, of course, we are looking for more data than just the basic data that the national health system is going to be capturing. But that's an undertaking that we, even, for example, the work that we did under the screening within the example we gave under the Matters Day. All that data is entering into the national health system. I agree with you that we need to refocus from just service delivery to the broader public health, and that's exactly what UPMB is doing. One of the questions that our facilities have been asking is that you're now saying, let's go to the community. Yet, we've been focusing our work, as Peter has put it, from the purchasing, rather from the performance-based financing mechanism where we are being rewarded. But we are saying, wait a minute, is that sustainable? Okay, yes, maybe the World Bank is bringing a grant into Uganda under that mechanism. What happens, okay, after that grant has been withheld? That's one. Two, are you true to the mission that you are established to do? And that's another question they're bringing. So for us as UPMB, we are now going backwards and say, how do we rethink and support these facilities? I just talked about the community health insurance component. In Uganda, we are yet to have a national health insurance system coming into the country. But for us as a network, we are saying, can we start our own and put it to scale? Mobilize the communities themselves to put aside resources. So that is the way we are looking at and saying, if we can't do it from the other side, can we start from the grassroots? Where these insurance schemes are working, the communities own these schemes, and the communities feel that the hospitals are their own. So in other words, they even safeguard the existence of this hospital, because they're like, if this hospital goes, we are finished. So they want the hospital to become better. They push questions of quality in the discussions with the hospital, and they ensure that the hospital is continuing to offer care. If management is bad, they also question the management and say that it's this particular staff, that is this management person who is not good. So to me, that's the issue that we are bringing up. Ownership by the community so that these hospitals survive. Otherwise, communities will quickly turn around and say, we're already seeing it, that the communities are saying we will abandon this hospital and even go to the public facility. I'll just give you a quick example. Through the World Bank project, Uganda is improving the infrastructure of the public system. Specifically, they're not looking at our system. They're saying, can we rebuild the hospitals, public hospitals? We're saying, what about our hospitals? They say, we don't have enough money. Let's first deal with this and then come back to your side. Now, as infrastructure improves in the public facilities, some communities are saying despite the improved infrastructure and public facilities, we will not go there, we will still go to this faith hospital because the people there, the service that is being given to us is more responsive to our needs. So to me, I think that is a critical undertaking that we must work on.
Thanks. Let's take our next question, and then it sounds like there's a lot of distortion coming out of this microphone. So maybe can you bring that microphone up?
If you hold it further down.
Oh.
You're fine.
Okay. So do this.
Hello, thank you everyone for a great presentation. My name is Peter Chibanyi. I have a calling in malaria prevention and Center for Private Health and Social Adjustment. It's a small organization based in Entebbe, Uganda, but also live here in Chicago. My question is both to Dr. Tonny or Alfred. Either two could answer it. Now, I was happy to hear about the launching, that the Ministry of Health was present. And I think you've answered partly of my question with the last question that was given. But I want to be specific and ask, is the government learning from your partnership, the government of Uganda? And also, besides learning, are they willing to follow what they are learning? Because we know our governments tend to, they might see some good, but might not follow through. So, and also if you're seeing that, how can you see that this happens on a policy side of the government, or the civilians, or the national side of things? So that's my question.
Okay, thank you. Is the government learning? Is it being translated into policy?
Let me start, and then Alfred will. I'm not a government spokesman. I just want to do a disclaimer on this. But I think from the time I've been working on this, I think government in Uganda is learning, specifically the Ministry of Health. The willingness to implement or to learn, rather to take forward what they're learning, is something else. But we are beginning to see some trickles in terms of their willingness to do this, especially looking at the non-communicable diseases and other areas. For this particular area, I would say the first evidence that they are willing to learn is that they have elevated a section of non-communicable diseases to a department level. So I think for me that is progress, because previously it was a one-man's department or section, and now that they are pushed to a department level, it now has a commissioner. It will have an assistant commissioner. It has already a principal medical officer. It will have some senior medical officers under. So I think to me that is progress. Two, we also see this in the health development plan that Uganda is implementing. So it has also been brought in under that level, and I think, to me, that is evidence that they are willing to learn. But also key is the issue of data, the issue of ensuring that non-communicable diseases are properly captured in the national health management information system. I think to me that is a critical one, because much of the data that we've been seeing has been undertaken by World Health Organization, but you don't seem to see data coming in from down and being utilized at facility level, at district level, and also at the ministry. So I think for me, from that side of things, it shows that yes, that government is learning, they are willing, and if we can then push this to another level of demonstrating what we've been able to do, how many people we've been able to reach, how many people have we been able to support in terms of preventing disease, and then those that possibly that were diagnosed have received the right treatment, then I think that will also help boost how government can respond to this epidemic.
Yeah, a quick one. For me, I would like to look at the willingness of the government to fight non-communicable diseases. The government of Uganda is very, very committed. And if you have heard, the president himself last year launched a National Physical Exercise Day as a way of trying to prevent non-communicable diseases. And then thereafter, different health departments have taken it up. I've learned that some of them on a weekly basis they do physical exercise as people in the offices. Then there's even discussion that I've heard that they're planning to introduce to make it like it's mandatory that every office should provide a facility for workers to be in position to do physical exercise. So in terms of, the government is very, very supportive. At the launch of this partnership, at that event, I remember very well the permanent secretary actually gave us an open door. He says we are open as and when you have initiatives that you want us to partner, please feel free. So we have that open door available to us to work with the government, and I would like to stay positive that it's heading in the right direction. So the support is there, and definitely whatever good work that UPMB does will definitely be looked at as a landing point.
Okay, great. We're definitely coming up on time, but we're going to take one last question.
Hi, my name is Caitlin Morse. This is more for Mona and Peter. You mentioned that as Ghana moved to being a middle-income country, that there was a shift in terms of the type of support that was available, and that was a bit of a difficult transition for some of the Christian networks. As we look in the context of health system strengthening, and as we look at the objectives that we've talked about today, what are some of the lessons that we could learn from what that transition was like for Ghana that could potentially be applied in other countries that are making similar transitions over the next decade?
Thank you very much. I'm told it's a Ghana question, so I have to answer Ghana question. Thank you very much. I think that having depended very much on donor support, now, euphemistically, it's called partnership support, still donor support, over the years, the transition to lower middle income country led to certain change in paradigm. So the switch came too fast without preparation. There was no phased approach, and the partner said, well, you are now a middle-income country, and that is a pity because if we get fascinated with showmanship of politicians, that may not necessarily cascade down to that level. So we have to start doing some soul searching. We have to start strengthening our service delivery as a way of having strong entry into the National Health Insurance Scheme, making sure that we focus on demand creation for our services, making sure that we'll build the necessary capacity so that at least we'll be able to generate a little bit of resources to sustain the service delivery that we have been good. I must say that's a challenge because the National Health Insurance Scheme itself is challenged. Often reimbursement takes about 6 months, 8 months delay in the rest. So it is a constant struggle. There are prospects in that sustainability, but there are also risks where, because of the need to survive, switching to survival mode means that sometimes doing unethical things, trying to look at patients as money-making, and getting deflected on this holistic approach to healing, looking at disease provision and the rest. I think these are the risks and challenges that we all have to learn. But it is inevitable. We recognize that one day, one time, all human relationship has an endpoint. But how do we plan, prepare, and anticipate such inevitable experiences? That's a challenge that all Christian faith providers must warm ourselves to. Do we have the necessary structures, capacity to anticipate this? How prepared are we as countries are yearning for lower middle income country? And as policies on journey to self-reliance are coming, definitely, one day, one time, we have to get ready. Question for all of us to answer.
So unfortunately, I think we're at time. It's 10:35, right? Is when we're supposed to. Okay. So we're going to have to wrap up the session. I'm sure our panelists would be happy to speak to people one-on-one if with any additional questions or comments you have. But for the purpose of this session, please join me in thanking our speakers today.